Good morning and welcome everyone. First of all, I would like to thank you all for registering to join our first episode of our Global Molecular Webinar series. Today we are kicking off by introducing our SARS-CoV-2 proficiency testing and findings from the QCMD SARS-CoV-2 EQA challenges in 2020. Today we are joined by Randox molecular product specialists Ben and Chris, and we extend a warm welcome to Technical Project Manager Dr Elaine McCulloch from QCMD. Throughout today's webinar, we plan to highlight our SARS-CoV-2 QC and EQA programs. Throughout the webinar series, we'll plan on not only discuss and highlight the importance of QC beyond the COVID-19 pandemic, along with introducing molecular EQA and reporting and interpretation. Throughout the series, we will also be highlighting molecular automation, introducing the consolidation of extraction, PCR, and detection for both laboratory and near-patient rapid syndromic testing, along with highlighting our IgG SARS-CoV-2 array detecting both MP and spike RBD proteins for SARS-CoV-2 antibodies as a method to discriminate vaccinated individuals from those naturally affected and verifying responses to COVID-19. I hope you all enjoyed today's webinar. This will also be available on demand shortly afterwards. Could I ask you all to keep your cameras off and microphones off? If you have any questions, please direct them to the public chat on the Microsoft Teams account, and someone in our team will get back to you. I am now going to pass to molecular product specialist Ben Crawford, who will discuss the importance of EQA.
Right, so we'll start off first by going over what EQA is, okay? Basically, I'm sure everyone here today knows sort of what external quality assurance is, but just for those who maybe don't, we'll cover that. So basically, external quality assurance, or EQA assessment, is inter-laboratory comparison of laboratory test performance relative to how other laboratories using the same or similar molecular test workflows. Basically, what happens is blind samples are sent to the participant, closely emulating clinical samples from a patient. So the samples that are sent out to the participants are very similar to what you get from patients. These samples are then tested by the participant on their workflows and then returned to the EQA provider. Results at this point undergo statistical analysis by the EQA provider. And basically, peer results are provided from that statistical analysis. Participants then receive a comparative report at the end of the EQA. Could you move on to the next slide, Marty? I don't seem to have control. So why would you run EQA? EQA enables a comparison of performance between labs. It provides confidence in the testing service that providing, so it provides confidence for end users of the laboratory, patients, and clients. It indicates areas for improvement and potential areas for training. It allows for peer group comparison to other molecular protocols and technology. It allows for large laboratory groups with multiple different sites and multiple different analyzers to draw comparisons between how each site is performing and also between how different analyzers within the group of labs are performing. It's educational, so it helps or it allows laboratories and users to keep up to date with current clinical and technological developments, new analyzers, new assays that are coming on the market. And importantly, it allows laboratories to meet quality management regulations such as ISO 15189-2012 or equivalent. It actually states within ISO 15189-2012 that EQA is mandatory. So ISO 15189-2012 states that the laboratory shall participate in an inter-laboratory comparison program such as an EQA or proficiency testing program. QCMD then. So what exactly is QCMD? QCMD is the world's largest EQA provider for molecular microbiology or molecular PCR methods. It's a fully ISO accredited, ISO to 17043 2010 accredited EQA provider. The focus is mainly on molecular infectious disease specific EQA schemes, so schemes which are specific for molecular methods for the detection of infectious diseases. QCMD is a world leader in the provision of molecular EQA for infectious diseases. It is an international clinical laboratory, reference laboratories and blood banks, as well as other end users. QCMD has a widespread collaborative network with users and collaborations with international organizations and national EQA providers. Presently, there's a very large offering of different EQA schemes from QCMD. Over 100 at the moment. These are provided in over 120 countries around the world with 14,000 annual registrations, so 14,000 different EQA schemes used each year. So to explain a little bit about the relationship between Randox and QCMD, essentially there's a collaboration, a distribution partnership between the two. Randox is recognized as a global leader in QC, both for Randox's IQC, internal quality controls, also EQA for chemistry through RICUS being the largest EQA provider for chemistry schemes in the world. QCMD is recognized as a world expert in the provision of molecular EQA. So the relationship between the two is quite good. It's quite an obvious relationship for the two to have. Basically, the strategic distribution partnership between Randox and QCMD is basically aimed at benefiting the end user, aimed at benefiting the lab. How does it do this? It aims at increasing laboratory access to QCMD EQA in new and emerging global markets. It improves laboratory access to QCMD EQA schemes through regional tenders and managed service contracts, particularly in areas of the world where it is difficult for customers to actually access QCMD directly or through the QCMD collaborative network. It aims at working with QCMD's existing network of collaborators further, broadening the awareness and benefits of quality assurance in molecular infectious diagnostics, and ultimately it aims to improve the quality of molecular testing around the world, ensuring that patients are receiving the best results. Now, there is a bit more detail on this available online, and you can go to either the QCMD website or the Randox website to find out information on that. Scheme operation then. So how does QCMD actually work? QCMD operates in a very similar way to how most EQA schemes work. At the start and at the top here, we can see we have the user, the end user, the laboratory participating in the EQA. And what will happen is the user will come to QCMD or go through Randox or one of the other partners of QCMD and register for EQA schemes. At this point, the user is provided with a login and credentials for an online portal, the Items QCMD online portal, where they can add their user details, add information about their analyzers, add information about their workflows, and so on. After this point, users will be distributed panels of EQA samples. There's different frequencies for different schemes around the world, but we'll talk about that in a moment. Once the users have received their samples from QCMD, they will run them on their molecular workflow, at which point they will obtain results. Those results are then returned to QCMD using the online Items portal, and QCMD provides statistical comparisons. Within 2 to 4 weeks of the submission of results, QCMD will then provide an individual report for each challenge. And then at the end of the year, or perhaps every 2 years, QCMD then will provide a supplementary report as well, which acts as providing extra educational information additional to the individual report. QCMD Items then is the web portal on which QCMD is operated, and we can see the front page of it here, the welcome dashboard of the QCMD Items portal. And basically it allows users to do various different things. It allows them to keep up to date on deadlines, registration deadlines, distribution deadlines, and so on. It allows them to add details about their laboratory, their addresses, their contact details, emails, phone numbers, and so on. It allows them to add information about the workflows they're using and the analyzers they're using. So what analyzers are there, how they work together to obtain the results for the QCMD samples. It allows the users to return the results quite easily to QCMD. And then on the portal, you're provided with both the individual reports for each challenge and then the supplementary report at the end of the year or every 2 years. So the benefits of QCMD, there's many benefits, but at the forefront of this is the samples that are provided. So QCMD provides what we call whole pathogen materials, and essentially whole pathogen samples are exactly the same as what you'll find in a patient sample. So they contain all the genetic material, the full genome that's normally included in the organisms that you'll be looking for. The only difference being that they are inactivated and safe to handle. The state-of-the-art molecular materials that are characterized are designed to support the assessment of the entire molecular workflow. So again, whole pathogen materials can be used exactly the same as a patient sample. They can be run from the very start of the assay right the way through to the result. The panels that are provided by QCMD are designed to be clinically appropriate for what you're testing. We include current clinically relevant strains in clinical matrices. QCMD provide an extensive range of genotypes, subtypes, and variants across various different EQA challenges as is appropriate. And the materials themselves are really well characterized, so quantitative characterization, qualitative, and sequencing where appropriate. The panels that are provided are both regulatory, so they meet regulatory requirements, and they are also educational, with a sufficient number of clinically representative samples to meet regional regulatory requirements. QCMD has a very large amount of participants, and this is great because it means that the peer groups and the statistical data that is provided is really good quality. So you can see here on this graph, there's been a consistent growth in the number of users of QCMD over time. But we can see here in this box, then there's some information about the 2019-2020 period. So at the moment, there's about 100 different EQA schemes on offer from QCMD, for which there are 178 different EQA challenges. There's 19 scheduled distribution of samples throughout the year, with 7,000 shipments, which is quite a lot. There's 14,000 annual registrations for the schemes, and they're provided in about 120 to 130 countries each year. But we have seen significant growth with that this year for our SARS-CoV-2 schemes. The samples that we provide are offered in two different types. So there are core samples and there are educational samples. Core samples are essentially proficiency samples that are expected to be detected correctly by the laboratory in order to show an acceptable level of proficiency or testing. Samples that are core are selected based on scientific information that's available at the time, clinical relevance, and also prior QCMD data for those organisms. Educational samples are slightly different. Educational samples are included in the EQA panel to basically assess or stress various aspects of assay performance, mainly specificity and sensitivity. Really good example of this will be our SARS-CoV-2 schemes, which include both SARS-CoV-2 and other non-SARS circulating coronavirus strains. This is in place to assess the specificity of an assay to SARS-CoV-2. In addition to that, we have serial dilutions or dilutions down near the limit of detection of most assays, again designed to stress the sensitivity of the assay. It is up to the laboratory concerned to determine whether or not their EQA results are in line with their expected performance and in line with regulatory requirements in their area, i.e. ISO 15189-2012. So QCMD do not pass or fail users based on their results for educational samples, but it is up to the lab themselves and their accreditors to decide whether their performance was adequate or not. QCMD provide comprehensive reports, and there's two different reports that are provided. There are individual reports, which are provided for each individual EQA challenge. So every time users receive samples, return results, within 2 to 4 weeks, they will receive an individual report. In addition to that, there is a supplementary report, which may be made available at the end of each year or each annual EQA cycle, but it can also be made available at a slightly lower frequency than that, depending on what is determined by QCMD. You can see here two examples of the reports. On the left, we have the individual report, which is basically providing immediate feedback on participants on how they performed and what samples were. And on the right is a supplementary report, which provides more in-depth data, which is not provided in the individual report. Individual reports have several different aims. The aim of the individual report is to provide immediate feedback to participants on panel composition, the expected results from the challenge or the distribution, the laboratory's performance within the challenge, how the laboratory compared to other participants within the challenge, and where appropriate, performance over time assessment. So QCMD sometimes include duplicate samples, replicate samples, to determine how the laboratory will perform over time when they're testing the same sample in duplicate or triplicate and so on. The reports meet the following criteria. So they are fully ISO compliant, laboratory regulatory requirements in terms of ISO 15189:2012 or equivalent are met. They contain all the relevant information to meet ISO 17043 as an EQA provider, and they are available very quickly within 2 to 4 weeks of the close of the EQA challenge. The supplementary report is slightly different. So the purpose of the supplementary report is to provide a general overview of the EQA scheme. It is to provide additional educational information which is not provided in the individual report. It comes in the form of a technical bulletin or a scientific report, and it's compiled by the QCMD groups of scientific experts for each of the schemes. They're released 1 to 2 years at the discretion of the scientific groups and also by the QCMD executive. QCMD also is quite flexible. So QCMD offers flexibility and frequency. Basically, with each of the schemes, there's different numbers of distributions available. So distribution frequencies, or the number of times that your distributed samples or challenges or panels throughout the year within an EQA scheme varies depending on countries and the regulations within them. QCMD schemes are flexible, and it allows you to choose a frequency which suits your needs and the regulations that you're subscribing to. Normal schemes, most schemes sort of typically have between 1 and 4 challenges. A good example of this is the HIV-1 RNA scheme, which we can see below. So in this particular scheme, we can see that there are 3 different versions available. There is a 1 challenge scheme, all at once in Q3. There is a 2 challenge scheme which distributes 4 samples in 2 distributions, once in Q1 and once in Q3. And then there is a 4 challenge scheme which will distribute 4 samples 4 times a year, so in Q1, 2, 3, and 4, meaning that you can meet both regulatory requirements, but you can also choose to pick an EQA that fits with your laboratory's throughput, its demands, and so on. So overall, QCMD has some major benefits. It has the widest selection of EQA schemes on the market. It offers frequency and flexibility of testing and challenges. Reports are available within 2 to 4 weeks. It's a fully accredited EQA provider to ISO 17043, provides an online, easy-to-use EQA management system, the items portal, has a very high level of participation, so over 14,000 registrations, meaning that the data and the peer groups that we offer is very large. It provides comprehensive, easy to understand and very clear reports, including vital comparisons for each sample tested. The materials included are whole pathogen, meaning they can be used on any analyzer from start to finish, from extraction through to result. They're highly characterized and clinically appropriate. And of course, discounts can be made on the inclusion of multiple EQA programs or annual registrations, which is something that Chris will talk about a little bit later on. But that's enough of me talking for now. I'll pass now on to Dr. Elaine McCulloch from QCMD, who will go through some of the detail of what happened this year with our SARS-CoV-2 schemes.
Hopefully you can hear me okay.
Loud and clear, Elaine.
Excellent. All right. Just before I start, I just wanted to mention, as well as having extensive distribution, we also have an extensive sort of network of scientific experts globally, and this helps us to adapt to the needs of the laboratories and quickly react to when we end up in a situation like we found ourselves with a new pandemic strain that labs have to quickly respond to and be able to test for. Just another example of this was back in 2015, about this time of year, Zika virus was starting to hit the headlines. And in the turn of the year in 2016, we started to get requests from diagnostic laboratories that they needed EQA to support their testing of Zika virus. In the beginning of February of 2016, the WHO declared the public health emergency, and by March we were able to announce our first Zika pilot programme. So that's just to show how quickly that we can respond when we found that there is a situation that labs need support with. And this is similar to how we have adapted and responded to the current SARS coronavirus pandemic. So EQA, as Ben's already explained, is critical to the laboratories. And when you find yourself in a pandemic situation, extensive laboratory testing is going to be essential. This is essential for infection control, patient management, and even managing populations and adapting to control infections. Molecular methods such as real-time PCR are going to be fundamental to this process because they are sensitive, they're scalable. Laboratories can easily, well, not easily, laboratories with molecular capabilities can add new methods and can start testing reasonably quickly. One thing that happened with the SARS coronavirus was the extremely rapid development of commercial tests as well. And there is always this sort of feeling that commercial equals a good test, but having external independent quality assessment and control is crucial to verify what manufacturers' claims are and to make sure that there is ongoing quality assurance. And proficiency testing is at the forefront. Yeah, the next slide. I just wanted to put a timeline in here just to highlight how things have progressed over the year. In the end of January, the WHO declared the public health emergency of international concern. By this point, we were already looking at SARS coronavirus because although we probably didn't quite foresee what was going to happen, we knew that this was an important new strain and we wanted to try and source the material anyway because we knew that laboratories would want to have this material available for future EQA schemes. And by the beginning of March, we had sourced well-characterised material. It was winging its way to Glasgow, and we were able to announce our first pilot EQA scheme. While we were preparing to distribute the scheme, we characterised the material ourselves. Internally here at QCMD, we use digital PCR to characterise material because we need some reference point to ensure that the material can be anchored and standardised, and when there is no international standard available, digital PCR gives us that ability. And obviously, as this was a brand new pathogen, there is no other standards available. Our first pilot was distributed in April, early April, and was extremely popular. And by the time we were running this programme and it was drawing to a close, we already had sufficient data and demand that we announced a full programme with both a 2-challenge format and a single challenge format, as well as what we call a multi-pathogen pilot, and we announced that at the end of May. The multi-pathogen pilot was brought about by already people were starting to look towards winter, and the fact that they were going to have to be able to deal with, as well as the SARS coronavirus pandemic, your routine winter viruses such as influenza and RSV. So QCMD has a number of multi-pathogen programmes. So we announced that we would distribute in Q4 a multi-pathogen programme that would include the SARS coronavirus, influenza and RSV to help laboratories that were using multiplex systems as they headed into the winter months. The first challenge of our full EQA was distributed early July, and we were able to react quickly and get the SARS coronavirus programme fully ISO 17043 accredited in August. So our coronavirus programme is now fully accredited. All our as well as being accredited EQA provider, our schemes are individually accredited as well to show that they meet the requirements of that standard and will support laboratories in their 15189 requirements. In mid-October, we distributed the second SARS coronavirus challenge, as well as the multi-pathogen programmes, and in the last week these programmes have closed and are currently under data analysis. So taking us back to the first pilot, we followed our standard specifications for our respiratory programmes. As Ben has already mentioned, we use cultured clinical material, whole pathogen material, and that's extremely important to ensure the samples replicate clinical samples. As this was a respiratory programme, the material was provided in transport medium. We already had some provisional data from 2 of our key expert centres, so we had a good idea of the clinical range that we wanted to target for the EQA scheme. We provide 1 ml samples, which is standard for most of our programmes. The samples are ready to use, they just need to be defrosted and tested. It's a qualitative programme, as you would expect for a respiratory virus. Again, we want to make sure that the panel material that we provide is suitable for various molecular methods. And we actually had some comments back that there was other EQA providers providing material at the same time or just after our programme, which was synthetic material and constructed constructs that were only covering certain gene targets, and this posed a problem to certain assays and wasn't suitable. Whereas as our programme contains whole pathogen, it covers all the gene targets. And a bit later on I'll show you some data to show why that's particularly important. So our first pilot was, as I could say, a very popular scheme. We had over 800 laboratories register for the scheme in 70 different countries. This brought about its own challenges as we were distributing this as the pandemic was peaking and the global transport links were shutting down, and a lot of our couriers use commercial flights to transport material, so that brought about its own challenges, but luckily we managed to overcome most of these. 688 of the laboratories that registered responded. Not all laboratories will return results to us, especially if they are still developing and implementing their testing. So that wasn't unusual for us to have less laboratories returning results. We had over 1,000 data sets returned to us. One of the things that QCMD allows is that you can return as many data sets to us as you wish. You're only limited by the material that we provide. And this is particularly important in larger laboratories. But in the coronavirus situation, there was a kind of everybody trying to use whatever platforms, methods, assays they could get their hands on. And because of shortages as well, that meant that some laboratories had 2, 3, 4 or more workflows they were using routinely just to meet the demand of testing. Everybody returned qualitative results, and there was a small proportion of people that also returned some form of quantitative data. For all our qualitative programmes, we will also collect quantitative data, and if that sufficient information is provided for a programme, we will provide that within the supplementary report as additional data. But only having less than 2% of the results, there was no further analysis performed on this. As I say, the laboratories as Ben has already indicated, they get sent the samples, they generate the results using their routine workflows and submit this through their dedicated online items profile. One addition, and this is completely unique to this pilot, was that we early on realised that laboratories needed instant feedback on what the panel contained, and we, on submission of results, we provided the laboratories with a panel composition rapid report. This allowed the laboratories to, before they even had their individual report that would give them their assessment, do their own work on troubleshooting, and it helped aid their own assay development. And because the situation was so fast moving, this was something extra that we could provide to help laboratories as they found their feet in coronavirus testing. But as standard, they still received their full individual EQA report at the end of the study to give them their peer group analysis and their own individual performance assessment. So just to show some of the early results that we got in this first pilot, we were pleasantly surprised that the performance was very good. In the high 90s for most of the core samples that we included in the panel. There was a slight drop in performance at the low-level sample, which was not totally unexpected. There was some lower performance on the non-SARS coronavirus types that were included in the panel. In this first panel, we included NL63 and OC43, which shows that some assays had some issues with specificity. There also was some specificity issues in the true negative sample. The next one. And if we look at the laboratories themselves, when we take the panel as a whole, as opposed to the individual samples, when you look at the core samples, participating laboratories, about 86% of them correctly identified all the core samples. And if you look at the individual data sets, that was about 83% of those data sets that correctly identified all the core samples. And this just is an indication that they may be struggling with a sensitivity or specificity on some samples that may be pulling down their performance slightly. And you can see that overall performance is slightly lower when you do include the educational samples into the overall assessment. When we looked deeper at the specificity, the true negative sample, there was just under 3% of data sets returned incorrect results. 3 of these were false positive results, and there was 11 not determined results. In QCMD, a not determined result is scored as being incorrect. When we investigated those results further, what we found that some but not all of the results were due to the first round of samples did not contain any human material. And because the laboratories were running them true to how they would a clinical sample, because there was no human material within the sample, they would have rejected that as an invalid sample. And that's something that we've picked up for future rounds. As I said, there's about 3% false positivity results on the non-coronavirus samples. And these were educational samples because we thought it's important laboratories know that the limitation of their assays, and their assays are unable to differentiate between the SARS coronavirus and the sort of seasonal routine coronaviruses circulating. We also challenged the participants with a sort of limit of detection sample. We knew that this low concentration sample would be close to the limit of detection for some assays. However, 86% of the data sets were able to correctly return a positive result for this sample, which was encouraging. And low concentration samples would become more important, potentially in the future when we were thinking that people would be screening as they are now non-symptomatic people as well as the symptomatic patients. Now, one of the things that Ben has highlighted as well, that we, where possible, always use whole pathogen samples. And this, I'm not expecting you to take all the information, highlights the importance of being able to cover multitudes of gene targets, because this slide here shows just some of the gene targets or gene target combinations that were used in the first pilot. This is doesn't form part of the formal assessment of the laboratories, but it is useful educational information that we have provided back to the laboratories as part of the supplementary report, because there is some differences in performance based on the target used by the laboratory or the combination of targets. So using an E-gene target, 98% of laboratories or data sets returned correct results, dropping to 93% when using an N-gene target. The majority of the results were returned using commercial assays. This is quite unique in a new pilot, because normally with new pilot schemes, people start off by creating their own assays, as commercial assays are not available, but almost instantly there was many commercial assays available, so they were very prominent early on in the study. There is a small percentage in this pie chart of 8% other gene targets, and the next slide shows that although this one highlights the main gene targets used, there is far more combinations were being used in this very first pilot study, which again highlights using the whole inactivated SARS coronavirus with the full genome ensured that the samples were compatible with whatever assay people chose to use. We also, in addition, collect CT values or CQ values to show some indication of the sort of quantity of virus detected in the samples. Now these, as we know, CQ values are not comparable between assays. They're just used purely for information as an indication. And you can see that although the median of the values show a nice serial drop as the dilutions go down between samples, the variation between the CT values returned is huge, and it shows that there is very little standardisation within different assay methods. So this is important as well if laboratories are using, even within their own institute, using multiple methods, the assays they're using are not intercomparable at this time. So from the first pilot study, this provided comparable information for different assays for the SARS coronavirus 2 detection. Overall, the qualitative performance of the participant laboratories was acceptable by what QCMD standards we would normally expect. It did highlight that there may be some analytical sensitivity and specificity issues in certain workflows, and we highlighted these as areas that laboratories may want to look for, or at least be aware of, when they are using particular methods. So we actually published the data of the first pilot study in July. So if anybody wants any further information, this information is available in Eurosurveillance, and provides more details on the first pilot study that was distributed in April and May. We felt it's important, and that's one of QCMD's other objectives, is to educate and disseminate as much information as possible, because it is important to help provide laboratories with as much information as possible so that continuous improvement can be made. So looking past the first pilot, as I said in July, we were able to distribute our full scheme, and the first challenge in July, this was the results returned from the first challenge. We had 400 participants, 400 data sets returned on this first challenge, and as you can see, the performance on the SARS coronavirus samples are good, and there's still this issue around specificity potentially being an issue in some data sets with non-SARS-CoV-2 coronaviruses. So, next slide. So, looking at the current and future schemes, our current and future schemes are all ISO 7. Well, I don't know what standard that is, but the RO is ISO 17043 accredited, and this accreditation was granted in August 2020. As I said, the commercially available kits were available very early in the pandemic, with about 80% of returned commercial results in the first pilot, and this was rose to 85% in the first challenge of the full programme. Also, the number of different manufacturers and different kits available was huge. There was over 95 different manufacturers in the first pilot. This did drop to around 58 in the first challenge. That's partly due to laboratories moving to either high throughput on big analysers and trying to consolidate their workflows, or also laboratories moving to rapid turnaround. So looking at your more point of care, Vivality type assays that can turn results around and can be used more directly with the clinic. So there was a bit of consolidation of manufacturers in that short period of time between the first pilot and the first challenge of the full programme. As I said earlier, the second challenge and the single challenge option of the full programme has just recently closed and is currently undergoing data analysis. And because of the winter demand for the multiple pathogen programme, we released the RES1 Plus programme, which was RSV, influenza and SARS-CoV-2 as a multi-targeted programme looking at people that are using multiplex workflows, and that programme has also just recently closed and is currently undergoing data analysis. Looking to the future and going into 2021, the next slide, we have tried to keep the programmes as flexible as possible. Obviously, SARS coronavirus, it's changing continuously. So what we have done is we have got a completely flexible format for 2021. We have 4 separate programmes effectively, one in each quarter. Each of these will be a 5 sample panel, still testing the same parameters as previous programmes with clinically appropriate levels near the limit of detection and specificity samples included. These will be distributed each quarter and laboratories can register for all or some or any combination they wish. And this was because we knew that laboratories would still be changing what their processes was, changing their testing strategies. So we wanted to keep everything as open and flexible as possible. So that's just a small taste of some of the activities that have been going on here at QCMD regarding SARS coronavirus. But we do other EQA schemes, although sometimes it hasn't felt like it at the moment. So I will pass you on to Chris, who I think is going to take over and go through some of the other schemes that are available.
Hi Elaine, thanks very much for a very comprehensive overview of the SARS-CoV-2 report. this is something that has been requested an awful lot. So thanks a lot for taking the time to go through that, and we really appreciate that. Yes, so just briefly at the end, as Elena says, the QCMD scheme for 2021 is now open. The scheme is now open for registration. And as Ben touched on earlier, there are substantial savings to be made for any labs who are able to enrol on an annual basis. So myself and Ben's email addresses will be displayed at the end of the slide. So if anyone wants to discuss this in more detail offline, we would be more than happy to do so. Okay, so regardless of what type of molecular testing a lab is offering, be that from the very basic, what they may think they're doing, or to the more complex labs, regardless of the setup, QCMD is a one-stop shop essentially for everything. If you look at the bloodborne virus programs, things like HIV, HBV and HCV, the central nervous systems, things like meningitis and encephalitis programs, congenital infections passed from the mother to baby. There are drug resistance programs. There are programs for exotic and emerging diseases. We'll touch on this a little bit further in a moment. Programs for intestinal infections for those with compromised immune systems. Then we also have the multiple pathogen or the syndromic test, ideal for people who are carrying out all the various different multiplexing that's going on at the moment. Then we've got our respiratory diseases, things like influenza A, B, RSV. Then we have our sexually transmitted infections, things like chlamydia trachomatis, Neisseria gonorrhea. We also have programs for transplant-associated diseases, things like Epstein-Barr virus or cytomegalovirus. We have programs for molecular typing, and then finally we have a list of new pilot studies. So I'm just going to go over this briefly and just give you a quick overview of the highlights just before we jump in and start answering any questions that maybe you have accumulated throughout this presentation today. Okay, so just a quick look at the pilot schemes. So the first pilot schemes that we're going to look at here are the emerging disease pilots. We've got 4 in total. The first one you'll see on the screen is for Babesa. Then we have a scheme for Chagas. Chagas is a big problem in Central and South America currently. Then we have a scheme for malaria. Malaria is a huge problem in the tropical and subtropical areas of the globe. And then finally, we have a new scheme for Francisella tularensis. And then there are new bloodborne virus pilot programs as well. Bloodborne viruses are a huge public health concern all over the globe. And when you mix in things like homelessness and drug abuse, it's sometimes extremely difficult to get venous blood samples from these patients. So as a result of this, QCMD are very happy to announce dry blood spot programs for HIV, HCV and HBV. And just continuing on the virus theme, there is a brand new scheme for HIV-2. And then just to touch on some of the respiratory schemes that there are available. Elaine already touched on this one already. Probably one of the most common assays of winter would be flu A/B RSV. With the onset of the pandemic, this is now morphed into flu A/B RSV SARS-CoV-2. We know there are a lot of manufacturers that have released this assay, and it seems like almost on a daily basis there are other molecular manufacturers announcing that they're going to either have this scheme or that they're currently working on this assay. So we expect this one to be extremely popular in 2021. Just continuing on the respiratory scheme, the respiratory thing, we got respiratory 2. This is suitable for those carrying out the large respiratory multiplex tests. In addition to that, we have respiratory 3, again suitable for the respiratory multiplex test, but this scheme is for the bacterial respiratory infections. And then just have a look at our traditional bloodborne virus schemes, HIV-1 DNA. There's HIV1 RNA, HIV1 DNA. Then we get hepatitis B virus, hepatitis C virus, and then there's also sexual health schemes, things like chlamydia, trachomatis, Neisseria, gonorrhea. And then finally, just a quick overview of the central nervous system infections. Things like varicella zoster virus, VZV, enterovirus, parechovirus, and herpes simplex virus, or HSV. So just before we get into any questions, I would just really like to thank you all for taking the time out of your day to listen to us. Also, thanks to those of you who will be listening in the future on the on-demand format. We really appreciate your attendance, and a very special thanks to Elaine from QCMD for dissecting what has been a really important program. The entire world is in a very precarious situation at the moment because of the COVID-19 pandemic. But that situation would be an awful lot worse if it wasn't for all the testing that's going on, and not only the testing, but also the robust quality control systems are in place to ensure that the correct results are being given to the patient. So what I'm going to do now, Martin is just going to look through any questions that have come in just in the meantime since the session has begun, and we'll be more than happy to answer some of those questions. So we'll just pass it back over to you again, Martin.
Thanks, Chris. Again, I just would like to thank everyone for attending today. We will be hosting a series of episodes throughout this molecular webinar going forward. I just would like to thank as well Elaine, Ben and Chris for taking time out of their day to present. I just took a look at the questions, and thank you all for your feedback. I just have one question for you, Elaine. So for the programs, the QCMD programs, are they suitable for all molecular workflows?
Yeah. Yes. Sorry, a bit of an echo there. For all our programs, we try to stick to the same format of using whole pathogens. This is not just unique to the SARS coronavirus program. We want to mimic the clinical samples as closely as possible, so that we can contain the whole genome. We're not limiting it to certain targeted regions. So yes, all the programs are generally suitable for all molecular workflows.
Thank you, Elaine. I think that's the main question that everyone was asking in the public chat there today. Again, I would like to thank everyone for attending today's presentation, and just so you can have a wee review again, and certificates will be presented on request. Again, I would like to thank you all.
That's fine. Yeah, I can just see a lot of people just asking about the catalog codes and different things coming in, but we can make that information available to everyone afterwards. So we'll send full details of all the new SARS-CoV-2 programs, the one that Elaine touched on briefly there earlier. I've got one other question, if you don't mind, Elaine. Do you experiment with any other transport methods other than dry ice?
For some of not all the programs are distributed on dry ice. We do have some programs that are lyophilized and shipped at ambient room temperature, but that isn't suitable for all programs. There is also it's also getting a balance right between the laboratories receiving a sample that looks exactly like the samples they would get clinically, because I'm sure that many clinical laboratories would receive lyophilized samples as standard. So there is a balance by using lyophilization as a method of changing the transport. But we do and are always looking at other ways, but at this time, to make sure that the samples represent what the samples represent clinically, we do continue to ship most of our samples on dry ice, but it is something that we are looking at for the future.
Okay, that's fine. That looks like pretty much all of the questions. To be honest with you, there are a lot of questions coming in, but as I said, they're pretty much just about the new programs, which we can easily make that information available for everyone. We'll contact you all by email afterwards and let you know about not only the SARS-CoV-2 programs, but also all of the other additional QCMD programs that are going to be running in 2021, and give you some information on how you can register and also how you can avail of those discounts for registering on an annual basis. So I think that pretty much concludes the session for today. So thanks a lot, everyone, for attending, and hopefully you will join us again in the future. We'll be running a series of different molecular webinars, as Martin had mentioned earlier on. So we will keep you all posted. This is going to be going on a monthly basis, so it'll be a different theme every month. So we will for sure keep you up to date, and we'll look forward to you all tuning in again at another event. Thanks a lot.
Thank you. Just to touch upon again what Chris has said about our series of molecular webinars, we will be hosting webinars based on our molecular automation systems, our point of care systems, and our new antibody MP and RBD arrays, with also looking at the rest of our molecular QCMD and QNOSIX programs and controls. Just to touch again, as Chris had mentioned, the webinar will be made available on the Randox website. Alternatively, you can contact both Ben and Chris and randox@marketing.com. Thank you everyone for taking your time today. That's the session concluded. Thank you.
Thanks a lot. Goodbye.
Goodbye.